quite extensive over an hour period. Inshallah, we'll try to do whatever that we can. Right. So my objective today is so that we can review this as a quick revision, as well as, if possible, we may clarify some of the concepts that sometimes may be a bit confusing to some people. So let us not waste any more time. We'll begin our session today, inshallah. All right. So there's a few topics that we'll be covering today. A bit of introduction, then the thoracic wall. We'll discuss about the pleural cavity, the bronchial tree and lungs, as well as the mediastinum. Right. So let me just move this there. Okay. First and foremost, we like to have a very broad idea. I'm sure all of you are medical doctors. This is a revision for all of us. To remember that the thorax is actually a cylinder, right? It comes in the form of a cylinder. But this cylinder is irregular in shape. Okay, it has a very unique pattern of this. And the function of the purpose of this particular shape is actually to accommodate its function, right? When we talk about the thorax, we must understand the border, right? So it begins superiorly as the superior thoracic aperture. And when we discuss about the inferior border or the boundary inferiorly, we are talking about the inferior thoracic aperture. The one superior is what I mean. Let me just see if I can. Right. We are talking about this structure over here, superiorly over here, which is the superior thoracic aperture, or also known as the thoracic inlet. Now, this is an open structure in which it is continuous with the neck. Whereas, when we talk about the inferior thoracic aperture, we are dealing with a closed structure. And this structure below here, we'll talk more about them later, is enclosed by the diaphragm. Now, you know that the function of the thorax is mainly for breathing purpose, isn't it? The ultimate function is to allow for air to come in as well as to escape, to get out from the thorax. So the ribs, the intercostal space, and all other structures over there, the main purpose is to allow for this movement of air into and also out of the lung. Secondly, remember that it is for protection purpose. So when we're talking about protection, all this bony rib cage and whatnot, all these are to house and to protect the heart, the lungs, great vessel, as well as abdominal viscera beneath it, below it. And the third function of the thorax is for, it serves as a conduit in which several structure passes through. You know, from the neck, they went all the way down to the abdomen by passing through the thorax, okay, from the neck to the abdomen through the thorax. Examples can be the esophagus, the vagus nerve, thoracic duct, the phrenic nerve, and so on and so forth. And there are certain structures that originate from the neck to the thorax or from the thorax to the abdomen and vice versa, right? For example, you have the trachea, the thoracic aorta, and the superior vena cava. Now, so as we mentioned just now, that this is a cylinder, meaning to say that we have a wall, there's a wall, and in the center, well, a cylinder will be hollow in the center, isn't it? Okay, so it forms a cavity internally, right? Of course, it is being filled up by structures, by organs, but the wall itself forms the thoracic cavity. So it is enclosed by the thoracic wall as well as the diaphragm. Now, if we are going to divide the thorax, it will be into three parts, okay? On the right and on the left, you will have the lung surrounded by the pleural cavity, right? By the pleural cavity. And right in the center, in the middle, what we have is the mediastinum. This will be occupying the central part or the median part of the thorax. So that's how it is going to be divided. So I think it's quite logical to start the discussion by dealing with the thoracic wall and to look at some of its clinical importance, okay, when you're dealing with patients, right? So a quick review on this, okay, we'll be looking at the thoracic wall, and the thoracic wall consists of it has the posterior, it is made up posteriorly by the 12 thoracic vertebra, right? The 12 thoracic vertebrae posteriorly, okay, forms this part of the wall. Laterally, you have the 12 ribs on each side, and anteriorly, you have the sternum, okay? And we know that the sternum consists of these three structures, isn't it? What will this be? That will be the manubrium, and then you have the body of the sternum, and right at the tip below is the xiphoid process. So all these three components made up the sternum itself. So this forms the anterior, it composes the anterior part of the wall. Then you have the 12 ribs, which forms the lateral border of the wall, as well as the 12 vertebrae at the posterior aspect. That's clear. Now, all the ribs, remember, articulate with the thoracic vertebra. Okay, they are in connection. They have articulation surface with the thoracic vertebrae. Most of the ribs have three articulation with the vertebral column. We are dealing with this, right? They are in articulation with the respective vertebra, as well as the one above it, and also with the transverse process of the respective vertebra. So there are three articulation points. Then this portion over here will form the head of the rib, okay? And the rest of this will be the body or the shaft of the rib. We know that it doesn't make contact directly to the sternum, but just before it meets the sternum, it gives out this cartilage, okay, known as the costal cartilage on the anterior aspect of the rib. Okay, this is just a little bit more of anatomy, okay, dealing to the specific aspect of this. So it will be helpful to know this when you're reading literature, for examples, okay, where you have the head and the tubercle and the neck in between them, okay, before it forms the angle, and you have this, the whole of the shaft or the body of the vertebra, before it continues anteriorly as the costal cartilage, which will articulate with the sternum anteriorly, right? Okay, but what I would like to highlight in this image is regarding the costal groove. Okay, we know the importance of this anatomy of the costal groove, right? Because it is at the costal groove several important structure lies, right? And knowing that this structure lies in the inferior border of the rib is important. So what you'll have over here, okay, this is the groove. If this is a cross section, if this is just a cross section of a rib, all right, what you'll have at the inferior border is this groove kind of structure, okay? And at this groove, there are several structures that lies within the groove, right? From superior to the inferior. And this is true for all of the ribs, okay? For all of the ribs, we have this structure. We'll talk about that more after this, eh? Okay, just a little bit more on the ribs itself, right? When you're looking anteriorly at all these ribs, right? Anatomists divide them into true ribs and false ribs, right? What's the meaning of this? The true ribs are ribs that actually connected, okay, via the costal cartilage directly to the sternum, right? So from rib number 1, from the first rib, second, third, fourth, fifth, sixth, 7, okay, it has a direct connection to the body of the sternum and to the what we call as to the angle or to the border between the body and the xiphoid process. All right, so the first upper ribs are considered as the true ribs, whereas the remaining ribs from 8, 9, 10, 11, 12, they are considered as false rib, simply because this rib doesn't make direct communication or contact articulation with the sternum itself, right? However, for rib number 11 and number 12, this is again, a bit atypical. They look differently because they doesn't make any contact at all, even indirectly. So they are called the floating ribs, right? We have the floating ribs. They do not articulate with other ribs, the costal cartilage, or the sternum, right? So there you have the true ribs and the false ribs. Okay, just a little bit to discuss regarding the superior thoracic aperture, right? We discussed this now, we said that the upper border or the upper boundary of the thorax itself is defined by the superior thoracic aperture. So what constitute this opening, or what constitute these inlets to the thorax, right? So there you have that posteriorly, it is bounded by the body of vertebra T1, thoracic number 1, right? And laterally, it is bounded by the rib, the first rib itself. So these ribs, which made up the first rib, it goes underneath the clavicle, right? In making this kind of like a C-shaped structure, okay? Really, is making the lateral border of the superior thoracic aperture. And anteriorly, it has a short costal cartilage which attached to the manubrium, right? To the manubrium. So the first rib connects with the first thoracic vertebra and with the manubrium. Now this whole structure over here, so they're making the thoracic inlets. So above this is going to be considered as part of the neck, right? So we discussed about the root of the neck. This is anything above here, whereas anything below here is considered as part of the thorax. But keep in mind that this first rib, right, it is making a slope orientation, meaning to say, if you can see me, right, it is not going to be at the parallel from T1 to the manubrium. It's not going to be somewhat parallel, okay, but rather it's making a slope downwards, okay, from posterior to inferior, from posterior to inferior. So the T1 will be much higher than the attachment where the manubrium is, right? So it's going to make, you can imagine that as someone tall, okay, going to hug someone very short, all right? So it is making all this orientation towards that, right? Okay, then, yeah, from this opening, structures are passing in and out, right? Structures are passing in through the neck. If it's directly from the neck, it's going to come down more vertically towards the mediastinum. It is going to get into the center part, directly into the mediastinum. How about the inferior thoracic aperture? We mentioned that this is a closed structure. It is being closed by the diaphragm itself. Posteriorly is by the body of the 12, by T12, body of T12. Then we have posterolaterally by rib number 12 and 11, okay, 12 and 11, which are the floating ribs, right? Anterolaterally, they are bounded by the costal cartilage of rib 7 till 10, okay? All this is also known as the costal margin, isn't it? Okay, the costal margin, which is easily palpable, right? So we have this. And anteriorly, it is bounded by the xiphoid process, okay? So it is closed by the diaphragm, but with some openings to allow structure to pass through. Okay, certain structure, such as the esophagus, the descending aorta, passes through, okay, passes through it. The anterior margin is higher than the posterior margin, yep. Okay. Right. I also like to discuss a little bit regarding the sternal angle, because the knowledge of the sternal angle is important, basically clinically, right? What is the sternal angle, right? We have the sternal angle, also known as the manubrio-sternal joint. Okay, you can see that clearly in this image over here, the one that I'm highlighting, right? Okay. Can you see me drawing something over there?
Yes.
Boleh, all right, thank you. So it is simply called the between the manubrium and the body of the sternum, isn't it? So it's the manubrio-sternal joint. also called the angle of Louis, ataupun to be more French, angle of Louis, right? So this angle of Louis, it is an elevated mark which is easily palpable, it is not much so by observation, but rather by palpation. It is easily to be palpable, okay, if you palpate, because there's an elevation. So it forms an angle, a slight angle, because the manubrium is tilted posteriorly backwards, okay, and this is more vertical, so it forms a little bit of elevation. Now, finding the sternal angle or the angle of Louis is important because it is the major landmark in counting ribs. And knowing to count ribs is, I think, a basic skills that all doctors learn, isn't it? Okay, and performing physical examination of the thorax. So by detecting or by getting the sternal angle, okay, it solves all the mysteries as where is the location of certain structures which lie in the thorax. That's number one, all right? By knowing it, might as well I tell you straight away, okay? Because the sternal angle correspond to the level of which ribs? It corresponds to the level of the second rib, isn't it? As you can see over here, the first rib is at the manubrium, but the second rib, okay, has the second intercostal, the second costal cartilage is in contact at the level of the sternal angle. So from there on, we are able to palpate and get the second rib, knowing that this is the second rib, the space in between, and then the third, the fourth, and so on and so forth. Right. That's number one. The second thing is also by knowing that this sternal angle, okay, this is a landmark in which if you draw an imaginary line, okay, a plane, you draw a plane which is horizontal or transverse, okay, right to the back, right from anterior you have the sternal angle, and posteriorly it goes to the level of T4, T5, okay, and this is a transverse plane, right? You're going to cross over several important structure that lies within the mediastinum, okay? So this is called the transverse thoracic plane, the transverse thoracic plane, some call it the transthoracic plane, and so on and so forth, right? So this transverse thoracic plane, so if you're able to hold that to feel for your sternal angle, right? Posterior to that, straight to the level of T4, T5 of the intervertebral disc, we find that this plane marks the separation between what is considered as superior mediastinum and what is considered as inferior mediastinum. So anything above that is the superior mediastinum, and whichever lies beneath it will be considered as the inferior mediastinum. We'll talk more about the mediastinum after this. Just at this point, that this is the demarcation area in which you have this plane that lies anteriorly at the sternal angle and posteriorly at T45, the intervertebral disc. It marks the superior border of the pericardium as well, right? Up to that level, it marks the superior border of the pericardium. Okay, so these are just some images, and I'm trying to correlate this with some clinical aspects that you know this, you can find the second rib, and you know the third rib, the fourth rib, the fifth rib, and this is helpful in order to put to where do you put the stethoscope for the purpose of auscultation, to listen to the heart lung, to the sounds of the sound of heart. Okay, so where is the best location to hear for the aortic valve, pulmonary valve, the tricuspid, and the mitral valve? Before we finish off with these ribs and the thoracic wall itself, okay, just another important skills for young doctors, for young doctors is to be able to read or to understand what they're looking at when doing a X-ray. This is typically important in the case of trauma, okay, where you suspect a patient may be having a trauma, trauma on the chest, okay, where the patient is also having a rib fracture, for example, and also in children, if you suspect non-accidental injuries and so on. These are the things that we look for, okay. In a chest X-ray, okay, it's important to delineate and to identify which ribs and at which level they are. Okay, so these skills of reading the chest X-ray is something that comes naturally once people study them. But just to give a few tips on that is by looking specifically at by identifying the first rib. Okay, if you look over here, okay, as I mentioned earlier, the first rib appears to be like a C-shaped structure. Okay, it's C-shaped, and it's going to cross over actually inferiorly to the clavicle, right? So by identifying that, okay, we are able to identify, okay, now we have the first rib as well as the clavicle, and from there on, you start to count for the ribs. Mind you, the one that you're looking over here, all these are from the posterior aspect, isn't it? Right? So by counting the second, the third, the fourth, and then by following these ribs towards the anterior aspect, it's important to see any breakage in the continuation of all these ribs. Okay. So this is what I mean. Okay, so we're able to identify each rib and correctly diagnose which ribs, fracture of which ribs, and if there are many segmental fracture together, you might be worried about flail chest and consideration for assisted ventilation and so on and so forth. Right, so then we come to the intercostal spaces. Are you all okay? Boleh, eh? Am I too fast?
Okay, boleh.
Okay. Sometimes I go too basic because I teach undergraduate students. But I think this is good revision if you follow along. Right. Then the intercostal space. Right. The intercostal space. This knowledge again important when you are dealing with patient which may require certain procedures on the chest. So the spaces are simply they are just space in between the ribs. So they are filled by the muscles, the intercostal muscles. So this is what these are the muscles. Okay, basically there are three flat muscles that occupies the intercostal space. Right, you have the externally, you have the external intercostal. In the middle, you have the internal intercostal, and towards the innermost. So the name suggests it is the innermost intercostal muscle. So three flat muscles occupying this space. And I would like to bring your attention between the internal intercostal and innermost intercostal. This is where you can find the neuromuscular bundle. Okay, neuromuscular bundle. And as I mentioned earlier just now, right, there lies at the costal groove, which lies at the inferior margin of the ribs, of each rib, at the inferior margin of the ribs. There's a groove, and this is where they are residing, right? And the arrangement for this is VAN. Okay, we have the veins most superiorly. Just beneath it is the artery, the intercostal artery. Then we have the intercostal nerve, right? The intercostal nerve. So they are lying at the inferior border, at the costal groove between the internal and the innermost intercostal muscle. Right. Okay. So there we are. This is just repetition. Three muscles: external, internal, innermost. Between the internal and the innermost, you have these vessels. So this is the neurovascular bundle, as we call it. It is important over there to note such arrangement, because it will have to do with the knowledge when you're passing in a tube, right? Okay, or a needle okay, somewhere in between, because in certain cases where you need to drain from the pleural cavity, either fluid or blood or air for that matter, will be passing through the structure. And frequently in exam, people like to ask regarding this, right? They will say, if you put in a needle in the chest for thoracosynthesis, for example, what structure will you pass through? Okay, so you have to identify, or you have to list down what structures that you will have to pass through in order to get into the pleural cavity, right? So if we go together, okay, so you pass through the skin, okay, and the superficial fascia, okay, the fascia over here. Then you have the external intercostal. Then you'll pass through the internal intercostal. Then you'll pass through the innermost intercostal muscle, right? And then only you'll pass through the parietal pleura, which we'll talk a bit later after this. So these are the structures that you'll be passing through, the needle will pass through, or the trocar will have to pass through in order to get into the pleural cavity. And the usual recommendation will be, whenever you pass in those needles or whatever apparatus that you have, is over the top of the rib. You go on top of the rib, superior to the rib, rather than inferior to the rib. Reason being, because at the inferior border, that's where lies the neuromuscular bundle, right? You want to avoid them. You don't want to cause any injury to the nerve or to the arteries and so on and so forth. So you always be advisable to go at the superior aspect of the rib. Of course, the space are very tiny, isn't it? So, but that will that is a measure taken to prevent injury to the especially the nerve, which lies the most inferior between the three, and the VAN. Okay, this is just another image signifying this. It's all simple, and again, it's on the putting in the trocar or the needle on the superior aspect of the ribs. Okay, these are other small muscles associated with the ribs: subcostalis, transversus, thoracis. Okay, they are tiny, but they are there in the ribs. A bit of the neurovascular bundle. We talked about the arteries just now. They are called the intercostal artery. It has two supplies. One is coming from posterior. The other one is coming from anterior. The one coming from the posterior is the main one, the much longer one, and they're coming directly from the descending aorta or the thoracic aorta. Okay, so these branches are coming directly, so they are giving the posterior intercostal artery. So it will be traveling all over, right, from behind to the front, from posterior to anterior. Right, and then the anterior intercostal artery derives from the subclavian artery, and from the subclavian artery anteriorly it gives rise to the internal thoracic artery. The internal thoracic artery. So the internal thoracic artery will pass down at in between the costal cartilage and the sternum. Okay, the body of the sternum will pass through down all the way, and then it will start to give out branches. And those are the anterior intercostal artery. The interior intercostal artery. Then the posterior and the posterior and anterior, okay, sorry, will anastomose, okay, and supply the thoracic wall or thoracic wall itself, right? Then as for the vein, it will drain into the azygous vein, and then all the internal thoracic vein into the brachiocephalic vein. You have lymph nodes all over, okay, in the parasternal area, the intercostal lymph nodes and the diaphragmatic nodes. And the nerves are supplied by the intercostal nerve from the T1 to T12 of the anterior mind, so giving the sensation, the somatic sensation to the body. I think this is the last one, not regarding the chest wall, in which just showing you what is usually referred to as the safe triangle. Okay, to insert the needle, okay, when you're performing a chest tube procedure, for example, it is advised to do it anterior to the latissimus dorsi. So it's anterior to the latissimus dorsi, and then lateral to the pectoralis major. So the pectoralis major will be here, so to be lateral to that, all right? and then you have the apex of the axilla, isn't it? Okay, so we're going to make this triangle, and so this line over here, this imaginary line, usually lies at the level of the fourth intercostal space. Okay, the fourth intercostal space. So anything above that will be considered safe. Anything that you goes more downwards or below, you have the risk of injury. Okay, injury on the right side, you may be injuring the liver and so on. So this is among the places where it is considered relatively safe to perform the chest tube insertion. Okay, now we'll move on to the pleural cavity, and then we'll go to the lungs itself. Okay, any questions so far? Okay. Okay, so I proceed. So now we are leaving the wall itself, the thoracic wall. We are entering the pleural cavity. What is the pleural cavity? These are the cavity, okay, a space, okay, which will go and surround the lungs and it lies between the parietal and visceral layer of pleura, right? So it has its own boundary, means it's going to cover everything. It's going to cover the lung itself. Superiorly, it extends up to the root of the neck, okay, even above the rib one. So it gets more into above rib one, okay. So it already gets into the root of the neck. Inferiorly, it is bounded by the diaphragm and the costal margin. Medially by the mediastinum, and laterally by the thoracic wall. So if you can see what I'm drawing over here, okay. So these thin sheets, okay, of structures over here, okay, forms the pleural cavity. Now, when we talk about the pleura, okay, some undergraduates get confused. They think pleura is part of the lung and so on. I need to stress that it is not, isn't it? Because there are two separate structures. The pleura is basically made out of mesothelium. Okay, this is just membrane, right? So we have two layers of membrane. Actually, there's one continuous membrane, but because of its reflection, so when you look at it, you look like as if there are two membranes, isn't it? But to be correctly saying this is that it is a continuous piece, a piece of membrane. Now this membrane, we have now we say it's two layers, okay, because it's been reflected, okay. As it goes along at the hilum of the lung, it gets reflected, so there's a reflection of this. So it comes back, and then you see that as if there's these two layers, right? One way of looking at this is, you know, the textbook will describe that the pleura is like a balloon, macam balon, macam balon. You have an inflated balloon, which is actually just a continuation, isn't it? The wall of it is just a continuation. Then you have your fist, okay, in the middle. Now your fist is the lung. Now this lung is expanding during developmental period. Is protruding inside it, okay. So now we have as if there's two layers of this wall of the balloon, one on the external and one which is surrounding the fist itself, right, which is surrounding the lung. So these two layers. So in between them, this is the space. So it's the pleural space or pleural cavity, right? So the parietal pleura lines the boundary of the cavity. So this is on the external part. Okay, let me draw that for you. So we have all this structure. This will be the parietal. This will be the parietal pleura, and it goes all the way. Okay, so from here it has the costal pleura, just the part, the costal pleura, cervical pleura. Here is the mediastinal pleura, and then it makes a reflection, okay, at the hilum of the lung, and then it'll be coming back. Okay, now, so we have the parietal and the visceral. The parietal pleura is very much intimate to the wall, to the thoracic wall, right? Whereas the visceral pleura is very intimate to the lung. It goes and surround the lung and adhere tightly to the lung. Betul-betul dia melekat dekat lung. So it's quite difficult to peel off this parietal pleura, visceral pleura from the lung. It goes all over into the fissure of the lung and so on. So it is very faithful to the lung. Whereas the parietal pleura is more on the rib, the costal area itself, and the diaphragm, right? So therefore, these two layers, by right, they should be separated. But no, okay, because we know that within the pleura, there is this fluid, a minimal fluid, the serous fluid. And with the presence of this minimal fluid, what it creates is that it sticks these two layers together, okay? Sticks to these two layers together. So they are in close contact to one another. It allows for movement, avoid the friction, which is very good, all right? And so on and so forth. But it also helps because, the visceral pleura is attached to the lung. So with that, the lung are also being expanded, it being brought outwards, okay? So that it's not going to be collapsed on its own. And remember that the lung is a very soft structure, soft tissue, right? It may collapse, but the visceral pleura, which is attached to the parietal pleura, keep it always in a state of being extended. And remember that this fluid, a little fluid over there, create a surface tension. This surface tension is important because, it makes it very sticky to one another. It's quite difficult to separate them now between the parietal and the visceral pleura. All right. And also remember that this is a potential space. We mentioned that, isn't it? It's a potential space. Usually there's nothing in between except for the very thin layer of serous fluid, but that may change in pathological condition. We have the pleural recess. Okay, the recesses are nothing but an extra parts in which the parietal pleura, two layers of parietal pleura are near to each other or opposed to one another. Okay, that's what you find over here. Over here, see the lungs doesn't cover the whole part of the extend all the way down. So what you have is this parietal pleura over here and parietal pleura over there. Both are parietal pleura. So this recess is called the costodiaphragmatic pleura. Okay, costodiaphragmatic pleura. But in full inspiration, this area will be obliterated. It will be obliterated. Takkan ada rest. Then we have the costomediastinal recess as well. So these are two notable recesses of the pleura. Innervation, the parietal pleura are innervated by somatic innervation. Therefore, it is bound to pain, temperature, touch, and so on. So there'll be pleuritic chest pain, where it's felt by the parietal pleura, whereas the visceral pleura are innervated by the visceral innervation. So they don't usually come and complain of pain, okay, especially associated with the visceral pleura. It is the sensation of stretch is going to be noted, but not so much of pain. But the one by the parietal pleura is a somatic one. Okay, right. So I think this is all about the pleura. In certain condition, we have the pleural effusion or hemothorax or even pneumothorax, or if there's pus in the pleural cavity and so on and so forth. At that point of time, this area will be, this cavity, this space is no longer just containing that minimal fluid. It's no longer going to contain just that minimal fluid, but will be occupied by either fluid, other fluid, or blood, or the air itself. So at that point of time, there'll be separation of the pleura. There'll be separation of the parietal and the visceral pleura. So therefore, it's not so much of a concern when you put in a needle, because we are always worried that we may puncture the lung, isn't it? Because in normal situation, the lung comes just parietal, visceral, lung. But in huge or massive hemothorax or pneumothorax, what we have is this separation. So whenever one put in the needle, and when you can feel the gift, or you can, the gift that is felt when pushing, so there will be still a space, okay, before it really. But of course, you have to correlate this with the clinical finding and the X-ray of the patient. Now let's move on to the bronchial tree and the lungs. All right, we know regarding the trachea. Right, the trachea is held open by the C-shaped transverse cartilage ring all the way down, and when it reaches the level the level of, remember just now we mentioned the transverse thoracic plane, the transverse thoracic plane, okay, which lies anteriorly at the level of sternal angle to the T45. At that level, it bifurcation. There's a bifurcation of the trachea into the right and to the left. So the trachea extend all the way from in the neck at the level of C6 all the way down to the mediastinum at the level of T4 and T5, between T4 and T5, right? And then it bifurcate into the right and left main bronchus, okay, main bronchus. So from there, let me just draw this a little bit. So this is the carina divided into the main bronchus or the primary bronchus. And from the main bronchus, or the primary bronchus, it's going to be further divided and further divided, right? So it's going to be further divided into lobar bronchi or secondary bronchi, right? And then it will be further divided into segmental bronchi or tertiary bronchi. So that's the pattern, okay? Airflow from the trachea, main bronchi, lobar bronchi, segmental bronchi. And after that, it'll continue as the bronchioles, okay? Bronchioles, respiratory bronchioles, terminal bronchiole into the alveolar for gaseous exchange. Just a little bit on the anatomy of the lung, okay? On the anatomy of the lung. The lung lies on the inside of the mediastinum, right? So the pulmonary arteries deliver the deoxygenated blood to the lung, and the oxygenated blood is returned to the left atrium via the pulmonary veins, right? So let us have a look, a quick look at the lung itself. This will be the anatomy of the lung. The lung is hemicone. That's how people describe it, because although it has this irregular pattern on itself, okay, it's considered as a hemicone in shape. It consists of a base, an apex, two surfaces, and three borders, right? So the base is associated with this diaphragm. Diaphragm lies on the diaphragm. It sits on the diaphragm. Then you have the apex on top, which project above rib 1 and into the root of the neck. So both the lung and the pleural cavity extend above rib 1. Sometimes they may go up to 3 centimeters above above rib 1. That also brings us to another importance worth to note regarding any procedure involving the area root of the neck, which may cause injury to the pleura and with extension to the lung itself. So one want to avoid iatrogenic injury to patients when considering doing the central line, okay, when you're in cannulating the subclavian veins, for example. So this is where one need to be careful not to injure the pleura as well, because it may extend above at the root of the neck. Besides that, it has two surfaces. The lungs have two surfaces. Mainly, we call them the costal surface, meaning the one that is in relation to the rib and the intercostal space, so the costal surface, and the one on the mediastinal surface, the one on the medial side. It has borders. It has three borders. Both lungs have three borders: the inferior border, the anterior border, and the posterior border. Okay, the inferior one will be sharp, anterior one will be sharp, but the posterior one is more blunt and it goes round. Okay, so it's not going to be a sharp one. A little bit on the what we call the differentiation between the right lung and the left lungs. The right lung the right lung has three lobes and two fissures, right? We have three lobes and two fissures. We have the superior lobe, middle lobe, and the inferior lobe. So the superior lobe and the middle lobe, they are separated by the horizontal fissure. separated by the horizontal fissure. There's another fissure over here known as the oblique fissure all the way down. So this oblique fissure is going to separate between the superior lobe and the inferior lobe. So 3 lobes, superior, middle, and inferior, with 2 fissures, oblique and horizontal. Now this area over here is known as the root of the lung. Okay, the root of the lung, which is surrounded by this structure called the hilum. Okay, that by the hilum. This area, the region of the hilum, is actually the area where the pleura is being reflected. Remember, we have the parietal, that it get reflected, and then it continues as the visceral. The visceral will surround the lung proper. Okay, so this forms a sleeves, okay, of connective tissues, right? So these are called the hilum area. This extension of this parietal pleura, of the reflection of the pleura, is called the pulmonary ligament. Pulmonary ligament. So what we can see over here in both lung, actually, these 3 main structure, which should be the bronchus, okay, the bronchus entering the lung. Then we have the pulmonary artery, okay, entering the lung, and the pulmonary vein, which carry oxygenated blood outwards. Okay, so the arrangement usually, generally, is that the artery is above the vein. The artery will be above the vein. That's number 1. How about the bronchus? The bronchus will usually lies on the posterior to them. Okay, it lies posterior to this structure. So that's it. Certain structure related to the heart, if you remove everything, the lung will give impression, isn't it? Because the soft tissue will give impression. Right, among the important notable structures in close contact, okay, relation in the mediastinum with the lung is the heart, the inferior vena cava, superior vena cava, right? The azygous vein, on its way to drain into the superior vena cava, and as well as the esophagus in the center, right? The esophagus over here. Then we have the left lung, right? Now the difference of the right and left over here is that the left lung consists of 2 lobes and a single fissure that separates them. So the 2 lobes over here will be the 2 lobes will be the superior lobes, will be the superior and the inferior lobe, and they are separated by the oblique fissure, and they are separated by the oblique fissure. And also note that the presence of lingula is present on right or left lungs. Okay, MCQ, usually people ask this kind of questions. Usually it's present only in the left lung. What are the structures which is related closely to the mediastinal aspect of the left lung? Of course, the heart, isn't it? Okay, we have the heart on the left side, more protruding to the left side. Then we have the aortic arch, okay, the arch of aorta. Then we have the thoracic aorta or the descending aorta, and the esophagus itself. So all this will give out impressions, okay, the heart impression over here, and other structures over here will be over there. We'll still have a little bit more time, okay. So we'll move on to the mediastinum. Is that okay?
Yes, doctor.
Yes, eh? Okay, good. Okay. Sekejap, kena air, Right. Now we're going to talk about the mediastinum, right? So just now earlier, I've defined the mediastinum. I said that this is the area that lies centrally on the central part or the medial part of the thorax. So on laterally, right and left, you have the lungs and the pleural cavity. Now we have in the center the mediastinum itself, right? Now, if you look at this image over here, we're going to delineate what are the borders that forms the mediastinum. Sometimes this is a bit confusing to people, and they are trying to figure out where exactly is the mediastinum. And then it comes to the what we call as the division of the mediastinum, right? If you're a radiologist, then you pay special attention, okay, to the sections of the mediastinum, because we need to identify what structure lies where in the superior or the inferior part of the mediastinum. So let us have a look. The mediastinum, the border of this, number one, on the lateral side, you have the pleura, isn't it? Okay, the pleura on each side. Remember that the pleural cavity on the right has no communication with the pleural cavity on the left. Therefore, any pathology of the right pleura or pleural space or pleural cavity on the right side may not have any connection with the one on the other side of the body. So this part is the pleura. Can you tell me which part of the pleura this is? This has been called the mediastinal pleura, isn't it? Because it's on the medial aspect, okay, rather than costal pleura or the cervical pleura or the diaphragmatic pleura. So this will be the mediastinal pleura. Then superior and inferior later after this. The anteriorly, it is bounded by the sternum, and posteriorly, it is bounded by the body of the thoracic vertebra. Okay, the thoracic vertebrae, many of them, right? So the sternum anteriorly, the bony part of the vertebra posteriorly, then the mediastinal pleura on the side. Now, then anteriorly and posteriorly, okay, anterior and posterior. Now you're looking from the side. Anteriorly, it is bordered, or it is demarcated by the superior thoracic aperture, because this is the part in the thorax itself, and inferiorly by the diaphragm. Okay, so do I have, yeah, if you look at this image, you're looking from front. Okay, you're looking at from the front. So this area over here is all the structure over here. If you minus the lung and the pleural cavity, this area in the center over here, all are being considered as part of the mediastinum. Okay, mediastinum. Now, then we come to what does the mediastinum contain? Oh, it has many structures, isn't it? Okay, all these structures are within the mediastinum itself. So you can name them. The list goes on and on, isn't it? We have the trachea passing through into the superior part of the mediastinum until it bifurcates to form the bronchus. Then you have the esophagus coming down all the way, okay, from the oral cavity, passing down into the neck, into the thorax, on its way to the abdomen, and the pericardial sac as well, which occupies quite large area over there, and the heart, with the great vessels of the heart, the aorta, superior vena cava, and the pulmonary trunk. Then also nerves passes through it, okay? For example, the phrenic nerve, the vagus nerve passes through it, and the thoracic duct, okay? The lymphatic channels also passes through the mediastinum with lymph nodes, and also the thymus gland. So it serves as a passageway for structure as they traverse the thorax on their way to the abdomen, okay? In some of the structures passing through the mediastinum itself. Now, do we have some more time? Okay, yes. Okay. Now we're talking about we divide the mediastinum into generally two parts. Okay, it's divided into superior mediastinum and inferior mediastinum, right? Superior mediastinum and inferior mediastinum. Now, and how do we divide this into superior and inferior? Is by that plane just now that we mentioned. You still recall the name of that plane, isn't it? It's a transverse thoracic plane, which lies from the sternal angle anteriorly to the T45 posteriorly. So that demarcates whether this is on the superior or the inferior part of the mediastinum. Remember, mediastinum is at the center part, tengah-tengah, the center part of the thorax. So whether it is above the sternal angle or beneath the sternal angle, so that's it. So we have the superior mediastinum or inferior mediastinum, right? Okay. Now, If you look at this image, you have the inferior part. We have the inferior part or inferior mediastinum. The inferior part is further divided into three. You have the anterior, the middle, and the posterior. So anteroposteriorly from front to the back is divided into three, the anterior, middle, and posterior. As for the anterior, it lies anterior to the pericardium. This will be the reference point, the pericardial sacs with the heart inside it, right? So this will lies as the middle mediastinum. The one anterior to that is the anterior mediastinum. The one posterior to that, until it reaches the thoracic vertebrae, this will be considered as the posterior mediastinum, right? Right. So looking at this image, okay, this will be the demarcation plane, right, of the transverse thoracic plane. So what are the structures that lies anterior to superior to that? That will be the content of the superior mediastinum. We have the esophagus and the trachea, the arch of the aorta with each branch with its major vessels, right? You also have the superior vena cava coming down, okay, so that it will enter the blood, the heart, right, and its tributaries, okay, to form the superior vena cava. And then we have the thymus and the thoracic duct, and also the vagus nerve and the phrenic nerve also passing through. Okay, don't forget the esophagus and the trachea. So these are the content, generally about the content, right? Looking at the CT scan of the chest, of the thorax, it's important to delineate the relation of each of these structure, okay, between one and another. In the medial mediastinum, right, anterior is simple. Anterior, there's not much structures passing through because we have the sternum, and then posterior to that is the fats with lymph nodes, right? And then you already come to the medial mediastinum. And the medial mediastinum is where the heart is located. The heart and the pericardium lies within this area. Then you have the ascending aorta. Besides that, you have the ascending aorta and pulmonary trunk, superior inferior vena cava continues into the medial mediastinum, and the phrenic nerve passing through in relation to the heart. Posteriorly, this is at the posterior mediastinum behind the pericardium. All right, these are certain structures that you find in the posterior mediastinum. You have the continuation. Remember, just now is the arch of the aorta, isn't it? The arch of aorta lies at the level of that transverse thoracic plane. Okay, we have the bifurcation of the bronchus as well as the beginning of the arch of aorta, and the ending of arch of aorta also lies at that plane, right? But then the continuation of this continues at the posterior part of the mediastinum, okay, all the way down, descending down. Then the continuation of the esophagus itself, okay, esophagus itself. Then you have the vagus nerve also passing through at the posterior mediastinum, okay, because the destination, the ultimate, is going to the to supply the alimentary canal, right? Okay, so the vagus nerve is going through. The thoracic duct, okay, is going on its journey to drain, okay, to drain into the veins. And then we have the system of azygous system, right? We have so the azygous vein is going to drain into the superior vena cava. So on its journey is also going to be found in the posterior mediastinum, and the sympathetic trunk, which also going to supply many structures in the thorax as well. So these are among of notable structures that is found in the posterior mediastinum, usually being questioned and asked in exams as well. I think that's all from me. Okay, I think I should stop here to allow you to continue with the next sessions. Right? If you have any question, you can ask me. Okay. If not, we'll end the session. Okay. Oh, okay. Perhaps last one. Okay. Clinical symptom mediastinal mass. If someone have mediastinal mass, knowing those structure important because it can give you an idea or clue if patient complain of such thing. You know that the trachea lies in the superior mediastinum. What will happen if there's a mass compressing it? Patient complain of dyspnea. Esophagus, patient complain of dysphagia. The superior vena cava, if something is compressing upon it, patient may come with symptoms and signs of congestion, head and neck congestions, right? And also the aorta, any compression to that, patient may complain of dizziness, syncope, and so on. Sometimes people consider this as mediastinal syndrome, where if the patient comes with various symptoms like this. Okay, so that's all from me. So thank you very much. Thank you for listening. Thank you. I wish you all the best. All right. I think I can pass over back to the chairperson. Stop sharing.
Thank you, Dr. Yusuf. It's actually we still have 1 minute left. We can open one question to the floor. Any question to Dr. Yusuf? Any question? Any question? I think Dr. Yusuf, you have a very excellent thought that no one's have a question.
They are still digesting.
Yeah, maybe most likely. I'm digesting as well.
But it's good to be the first speaker in the morning.
Oh, true. Everyone is very focused. Amira, do you have any question?
Since you asked, then I asked one question, Dr. Yusuf.
Yes.
If let's say we have a retrosternal thyroid, so how it pass downward into the sternal area from the neck?
From the neck. Okay, perhaps when you learn about the neck, discuss about the neck anatomy. So it may extend down, and that's why it's being described that it is going to pass through the thoracic inlet, which is the superior thoracic aperture, and it will extend downwards all to the extent to the superior mediastinum. Okay, superior mediastinum. So again, this is considered an external mass that passes through within the mediastinum itself. Okay, so therefore you look for symptoms that may indicate there is a mass expanding or getting bigger, which may affect structures in the superior mediastinum. Okay, so yes, it is a direct continuation from the thyroid itself, where it is. Now it's becoming pathological and extending downwards.
So it come in front of the superior vena cava. I mean,
by the?
It is in front of the SVC, is it?
It is going to extend down in front of the trachea.
In front of the trachea. Okay.
Yeah. All right.
Okay. Thank you.
Okay.
Thank you, Amira, for your question. So I think that's the only question that we can able to afford. Yeah. So thank you, Dr. Yusuf. Yeah. For your very good lecture. Thanks.
Thank you very much.
Yeah. Thank you.
Right. Thank you. Assalamualaikum.